Good morning and welcome to the Connecticut Health Council's The Hidden Epidemic. My name is David Griggs. I'm President and CEO of the Metro Hartford Alliance, and I would like to hand it off eventually to Barry Simon, our Health Council Board Chair. But before I do, I'd like to announce something of particular interest to the Health Council, the hiring of our new Executive Director for the Connecticut Health Council, Dawn Johnson. Dawn comes to us as a master prepared registered nurse with a diverse background. Dawn has worked with multiple federal agencies, state governments, and community and private associations and health ecosystem partners. Ms. Johnson's professional experience includes more than 10 years of management consulting with health systems, payers, providers, and government agencies on population health, strategy development and execution, stakeholder engagement and facilitation, and interpreting health policy for market viability. We're excited to have Dawn join our staff as of today. She's got well over 25 years of healthcare leadership, management, and clinical experience. I look forward to all of you being able to meet Dawn over the coming days and weeks and months and years as we continue the important work that the Connecticut Health Council has undertook. With that, I will hand it over to Barry Simon. Thank you, Barry, for your leadership of the Health Council and all the work that you do for our community.
So, well, thank you, David, and really exciting news, and so glad that we're able to announce this. I know it was a real pleasure meeting Dawn, and as chair of the board, I really look forward to working for the Connecticut Health Council to be working with her, and just excited. The Connecticut Health Council as a group of sector leaders who work together to promote Connecticut as a premier center of excellence. Certainly having her in that role is going to really help us to achieve our mission. I also am really looking forward to today's presentation. Certainly the hidden epidemic is something that employers really need to be working and concerned about and working towards solutions. And so today's panel has experts that can really give us a heads up on what we're looking for. And moderating today's panel, Dr. Harvey Kaufman has served in a variety of roles in 29 years at Quest Diagnostics, including as its first chief lab officer and starting as regional medical director of New England. Dr. Kaufman leads Quest Diagnostics health trends that provide public health insights based on Quest Diagnostic data. He lives in neighboring Massachusetts, and as the Senior Medical Director of Medical Informatics and Office of the Chief Medical Officer, really putting action from insight, as the tagline is really what they are all about. So I'm really looking forward to today's presentation, excited about the panelists, and Dr. Kaufman, I'm going to turn it over to you, and thank you.
Thank you, Barry. Thank you, David. Welcome, Dawn, and welcome, everyone. So let's just quickly, we're going to go through the slides quickly, and next slide, please. So we're at a crossroads as we transition to a more open communities. As our communities reopen, we're faced with new challenges such as how do we work, how do we learn, how do we play, how do we address the neglected healthcare that's happened during this pandemic. During the pandemic, many of us have deferred care. First, as directed by the Centers for Disease Control, the CDC, and many others, particularly during that early surge that sort of swallowed New England, Connecticut included, New York and New Jersey. And although healthcare services have resumed, there's still a tsunami of patients with delayed care. And the question for today and tomorrow is, how do we prepare? As the Bob Dylan song goes, how much suffering and how many deaths will it take for us to know? The answer is not blowing the wind, the answer is in our hands. Next slide, please. So let me set the stage in terms of the gap in care. And I'll start with survey data from the Harris poll. It's one of the longest running surveys of American views and attitudes. It was commissioned by Quest Diagnostics. It was conducted in November of 2020. Over 2,000 adults participated. Some of the key findings is that at the time, over 1/3 of Americans did not plan to resume attending in-person medical treatments or appointments until the pandemic was under better control or a vaccine was available. We passed both thresholds. And 1 in 2 Americans said that only a severe illness or injury would motivate them to seek in-person medical care during the pandemic. And this speaks about our resistance and about sort of resistance to seeking related healthcare services. Next slide, please. Here's 2 other points, and they speak to the degree of delayed diagnosis and racial differences. 1 in 2 Blacks are concerned that they currently have an undiagnosed health condition compared to 39% of white Americans. Both numbers are astounding. A majority of Americans, 60%, said that they skipped or delayed some in-person medical treatment or appointment during the pandemic, especially Hispanic, Latinx Americans, higher rates than in white and Black Americans. But it's astounding rates. The next slide comes from Epic Health Research Network. It's a large collection of hospitals that use Epic. Routine screening for breast cancer, colorectal cancer, cervical cancer fell by 85 to 90% at its nadir, and at best returned to the 2019 baseline level in the second half of 2020, not quite shown here because the data didn't extend to that time. So this represents, if you look at it collectively, is an 8 to 15% gap in care and preventative services care in 2020 versus 2019. And we've seen bigger gaps in younger patients who've skipped preventive services. So in the next 9 slides, which I'm going to roll through quickly, I'll highlight some Quest Diagnostics data that's specific to Connecticut and extends through the end of 2020. So next slide, please. So first, I want to demonstrate that the data is representative of Connecticut. So I looked at PSA testing, which is prostate-specific antigen, looking at enlarged prostates and prostate cancer. So in 2018 to 20, we had a little over 500,000 specimens, and you can see the distribution of the testing versus the census data, and it matches relatively well. And note that 3 of the counties represent 3 out of 4 residents in Connecticut. And next slide, and here's what happened to PSA. So that yellow line is the 2020 year. You can see what happened, which is that there was a major drop, a plunge in mid-March that extended through May, and testing did resume back to pre-pandemic levels. If you look at January, February of 2020, it's a little higher, and it's a little higher for the second half of 2020, consistent with that early part. But notice that there's no recovery. There's no capture of those lost cases. Next slide shows the distribution by county. And again, it's pretty evenly distributed in terms of where the gap was. So next slide, moving from older patients to younger patients, this looks at pediatric lead testing. Not quite sure what that surge was in the early 2 weeks in March of 2020, but we do see that big plunge during the early stage of the pandemic, and it never quite comes back to the 2019 baseline. It's a little below and never recovers that gap. Next slide. And here's the distribution by county. We can see that there's some spread in those numbers. So there's definitely some variance in terms of where the gap is. Next slide. So one of the unfortunate issues facing us as a society is opioid drug overdoses and deaths, and a lot of that's led by fentanyl. So this looks at fentanyl testing and positivity, and we can see that the positivity rate stays pretty much the same in 2019 and 2020, but the volume of testing plunges in that early surge and never comes back. So there's a couple of issues here. One is that program enrollment, treatment program dropped a lot and people didn't fill those slots. and there was reduced testing. So a consequence of this pandemic is a drug misuse and drug overdose epidemic. And it surged in 2020. And given the importance of testing and treatment, we're likely to have exacerbated the situation in 2021. And then I turn to the second to last example, which is chlamydia testing. Testing patterns dropped. Okay, there's the, interesting enough, Litchfield County had an increase, but the other counties, some spread in there in terms of testing for fentanyl. And then next slide. So this looks at testing for chlamydia 2019 versus 2020. We see the plunge and it comes back somewhat in the second half of 2020. Notice that the positivity rate in that March, April, May period went up, and that's because more symptomatic individuals were likely to have been tested versus asymptomatic individuals. 80% of chlamydia infections are asymptomatic, which is why testing is so important. So that's why that positivity went up and then sort of reverts back to the 2019 pattern. But there's a gap. So there's two things that are different here. One is for chlamydia and sexually transmitted infections, we have what's used to be referred to, still is, disease infection specialist. We now refer to them as it pertains to COVID-19 as contact tracers. So the disease interventionalists switched their interest intentionally to focus on the pandemic. So they lost focus intentionally on the sexually transmitted infections. The other issue that happened, and you see somewhat a little dip in here, is that there was a shortage of swabs. The swab manufacturers switched manufacturing to support the pandemic, and there was a shortage of swabs for chlamydia and gonorrhea. So we've got a mixture of issues here that sort of complicate the issue. And what's going to happen as a consequence is going to be felt for years in terms of the increased spread of chlamydia and gonorrhea and increased rates of pelvic inflammatory disease, ectopic pregnancies, and infertility. And then the final, and so just before I move on, national data was presented in a publication on May 19th in American Journal of Preventive Medicine that you can look up. The next example also was published in the American Journal of Preventive Medicine. Next slide, please. And this came out May 10th that looks at trends for hepatitis C, both testing and treatment. It was a collaboration with the Centers for Disease Control. Hepatitis C is targeted for elimination by the World Health Organization and the Centers for Disease Control by 2030. We were making good progress and stepped backwards in 2020. So the number of confirmed cases, which is on the right, on the left, actually, so this is antibody testing, it plunged, but on the right-hand side, we looked at the confirmed cases, which is the hepatitis C virus RNA positives and treatment. This is pulled from the IBM market scan data, both decreased by, in round numbers, 40% by July of 2020. So this means more people are going to spread hepatitis C to others, more will develop consequences, including cirrhosis and liver cancer. And we've taken a step back from the elimination goals. So what I laid out very quickly was the new epidemic of undiagnosed people who now inundate the system. There's going to be a tsunami of these folks who are going to present, some are going to present at later stages, require more aggressive therapy, and some will have higher risk of death. Dr. Ned Sharpless, who's the director of the National Cancer Institute, already estimates that we will reverse downward trends in cancer mortality, and will be increases for the next decade, is what he's forecasting. In economic terms, we talk about demand and supply, and the demand for services will be stronger than ever. The need to address the supply side of the equation is what we're going to talk about in this panel. The panelist is amazing. We have Kate McEvoy, who's Director of Division of Health Services at the Connecticut Department of Social Services, Robert Kosior, who is Vice President of Pharmacy and Medical Cost at ConnectiCare and EmblemHealth. We have Roberta Wachtelhausen, President of WellSpark Health. Eric Daigle, I love his title, Head of People and Culture. The challenges are large and evolving. As one of our panelists said in one of our prep sessions, it's a whole new world. We face a myriad of unaddressed physical and mental health issues. In addition, we have the ongoing issues of depression, drug misuse, pediatric lead, sexually transmitted infections, obesity, the list goes on. We have limited resources. In many ways, healthcare budget savings during the pandemic are likely to be offset by higher expenses now and for years to come. The fundamental question is, how do we use these resources better? What should we de-emphasize, and where do we need to focus more of our resources? What are the short-term fixes? What are the long-term fixes? And so let's start with one approach that has exploded during the pandemic, which is telemedicine. For those with internet connections, this is great. Those who hate long lines, this is great. But for those, we lose the in-person kind of connection. It's hard to do physical exams. Surveys suggest a mixed reaction by both patients and providers. We need to learn how better to use telemedicine for mutual satisfaction. And so really, what's next for telemedicine? And I'll start with Kate.
Good morning. Thank you so much for that wonderful context. I think it is definitely a call to action to all of us. I will say on behalf of Connecticut Husky Health, that's our Medicaid and Children's Health Insurance program in Connecticut. We joined sister programs across the nation and rapidly rolling out an extensive portfolio of telehealth options early in the pandemic. This was practically unprecedented for most Medicaid programs. There was little applied experience. And so it was, I think, a quick test of the proposition of the hypotheses around access and utilization, member experience of care. We rolled out telehealth in all of our major service categories, medical, behavioral health, but also in some of the long-term services and supports. It was a major enabling strategy for people who were homebound during the pandemic for all kinds of reasons, including disability. And that has given us a unique lead on kind of the entire array, examining what we're forecasting we will make permanent, and likely a broad swath of that authority will be considered on that basis. As you may be aware, we did roll that out in many cases, both for video conferencing and also for audio-only calls. And the audio-only feature was a major enabler for some folks in our population, notably individuals who are not stably housed, who practically speaking had little other option around the use of the video connectivity. So I just flagged that as a major component for our complex need folks ongoing. We also saw rapid uptake among providers. We're really grateful for the provider willingness to come along with us in that trajectory. And we are proud because we've had very proximate data on the utilization that's enabled us to examine trends. Since we are a self-insured program, our affiliate medical administrative services organization, CHNCT, was able to really provide us rolling data that showed the array of services, the incidence of providers taking this up, and also showing us data based on surveys of Husky Health members and also providers that showed a fairly unqualified positive experience. I think your comments are well taken in terms of evaluating the qualitative piece around the comparison of virtual to in-person visits. But I'd say we have solid premise undergirded by data to really look at building this in as a permanent feature of our program.
Thank you, Kate. Robert.
Good morning, everyone. So yeah, I mean, telehealth has really been probably the most talked about aspect of healthcare delivery as a result of the pandemic, and absolutely critical, particularly in the early stages of the pandemic when physician offices were closed, and really the only way that most people could access needed care or a provider was really through telehealth. And I think it's really important to note that telehealth really was around prior to the pandemic, and really there was really two different models of telehealth. And one of the things that we're seeing as a result of the pandemic is really the convergence of those two models. Really, the first model was really an offering that ConnectiCare started in 2016, and many other health plans did the same, which is really offering a national provider network of telehealth-only providers that really was offered as a lower cost option and a convenience for our members so that they didn't have to leave their homes. They could literally either pick up their smartphone, have an audio video conversation, have an audio only conversation from the comfort of their home, mostly to deal with sort of lower acuity type conditions, colds, coughs, sometimes a skin infection if you had a good camera phone, those kinds of things. And again, it was a very low cost option. The cost of that service was significantly lower than a traditional physician visit. And then there was a very different model, and that other model really kind of more fell into the context of our existing physician contracts and reimbursement methodology, and it really followed the Medicare definition of telehealth, which was really quite stringent at the time prior to the pandemic. And there were some really key elements to that. One is there was this requirement around originating site, which meant that, you know, the virtual part of that service was more geared to the physician being virtual, not the member or the patient being virtual. The patient actually had to be in a clinical setting. And it was the provider that was virtual. And again, pre-pandemic, that really made sense because you think about it, you're in an exam room, you have access to nurses and support staff. They can take vital signs, they can do diagnostic testing, and they can essentially communicate that to the provider who is somewhere else. And then the other requirement that CMS and the other health plans had was that the encounter had to be both audio and video. Now, obviously, when you're in a pandemic, that doesn't work. So one of the modifications that ConnectiCare made, pretty much all of the health insurers made, and CMS made, was to really get rid of that restriction around originating site, which means that these services now can get delivered within a patient's home. And also, we waived the requirement that it be audio and video, which means that if someone didn't have access to a smartphone with a video camera, they can also access physician services because they can do it via audio only. So again, you see both of these models now converging, and I think really the conversation really going forward here is, you know, what does that look like, you know, in the future? And then if you look at kind of the distribution of services, what you see here is something very different on the medical side versus what you see on the behavioral health side. So in the early parts of the pandemic, we were seeing that the distribution of physician visits on the medical side, particularly in the months of April, May, and June, was well in excess of 50%. And I think it was the month of May, it was really close to 70%. So 70% of those physician encounters were virtual. However, if you fast forward and you look at what's happening today, we have gone back to a distribution that favors in-person visits significantly more. So currently, if you look at our commercial population, our virtual visits are running about 15%. For our Medicare members who tend to be a little bit older, they're running in the high single digits. And so that, I think, tells you a little bit about patient preferences and physician preferences, right? I think that there was a survey that we did early on. Certainly our members valued having access to virtual visits, but I think overwhelmingly the survey showed that they preferred in-person visits over virtual visits. We're seeing something dramatically different, though, on the behavioral health side. On the behavioral health side, much like on the medical side, there was this very rapid transition to virtual care. Up to about 70% of behavioral health visits were done virtually. We're actually seeing that being sustained right now. So there is certainly a very different pattern that's emerging on the behavioral health side versus on the medical side. So what does this hold in the future? You know, I think that I don't think we'll go back to that traditional definition of telehealth. I think there's much more flexibility that we need to have for our members and our patients in terms of how they access care. I think the concern that we have as a health insurer is we want to make sure that people, both physicians and our members and patients, are making the right choices in terms of knowing when an in-person visit is appropriate and versus when a virtual visit is appropriate. So, and that's something that's really not going to emerge for some time now until we are able to collect more data on that.
I have a daughter who's a high school teacher, and I think she got more training on how to do the Zoom teaching than most doctors, far more training than I think doctors received. Sort of just some feedback that the providers also could benefit from some additional training. Roberta, you can add there, or we can sort of get into a different topic. You have something to add?
No, I'll take your question, Harvey. I think
Okay.
it'll tie right into some of the things that Rob and Kate have been talking about. So
Yeah, so social isolation, depression, anxiety were all exacerbated during the pandemic. How do we address the acute need in 2021?
Well, certainly what we're seeing at WellSpark, and just to take a step back, we provide well-being solutions for employers. And we're really focused on our model, and our approach is a biopsychosocial approach. So if you think about it, we view health and people and employees, they're the sum of everything in their life. So if you're not contemplating the psycho and social aspects of a person's life, a total person health view, then you're really missing out. And as an employer, we believe your programs and your benefits that you may have are going to fall short. And so, Harvey, as I think about your question, and I think about what some of the others have said about, screenings are down, and there is a tsunami of mental health issues coming. From an employer's point of view, I think you have to really be focused on encouraging and incenting your employees to get screenings. And a lot of employers do that. But there's also tools in an employee benefits toolbox for an employer that I think you really have to take a step back and say, are they working for you as an employer? Pre-pandemic, we would argue at WellSpark that they weren't working as they should. It's a fragmented benefits landscape. If you have sick care, you go here. If you have behavioral health issues, you go here. And you might be accessing those in a new way, as Rob was saying. But really, where is the social aspect of this? And the only tool an employer had in their toolbox was an employee assistance program, which if you're an employer, you probably chuckle because you have it and you check the box, but no one really uses it. No one uses it. So in a post-pandemic world, as people are coming back to work, employers are asking themselves, is the tool set I have, is it really effective? Is it really working? And I think employers also have to ask themselves, what do they do for the other half of their employee population that may not have benefits? I mean, the Kaiser Family Foundation came out with a study in January of 2021 that said only about half, 49% of Americans have employer-sponsored health insurance. So you may have benefits, but what are you doing as an employer to really address the culture of well-being? And this is where we're really focused right now, is working with employers and stepping back and saying, what has worked, what isn't? How do you provide incentives perhaps for employees to seek services when they need it, the right kind of services, preventive care, gaps in screening, and that kind of thing? But what are you doing to address the barriers that someone may have to accessing those services? And it might be stigma, but it might be very real. It might be transportation and some other social determinants. And so our model is really focused on biopsychosocial, and we're really working with employers right now who are saying, you know what, my employee benefits suite, it's kind of out of the box. It hasn't really worked. It hasn't been effective. It doesn't meet the needs of my entire employee population. And so what can we do to really connect people with the programming that we have? And so this is what we've been doing since 2018 with this model. And the pandemic has really shined the light on the need for connecting the entire workforce to programming that's culturally relevant, but really meeting their psychological and social needs for connectedness.
Thank you. So Eric, I'm going to focus on you next, which is Roberta talked about that we have sick care, we have well care. And the question is, what can be offered to both in-office and at-home workers and their families to sort of drive towards better health? Now, I'm older. Smoke cessation programs at one point was somewhat controversial as we were somehow intruding into people's personal life. But now that we've had them now for 30 years, they've been successful. We can do more, but they've been successful. That we've sort of migrated to weight loss, and exercise programs have had some mixed results. What's next? How can we get and engage our employees and their families and not seem too intrusive?
Yeah, I think that's a great question. At times, I would say that employer-sponsored programs, can be very sort of prescribed, if you will, and not tailored to the individual's needs. And I think smoking cessation is one of those programs. It's critical to get to the root cause of why someone continues to smoke. There may be mental health components, it may be stress, and I think that's probably the missing link with some of these things. We partnered with WellSpark just about a year ago at this point in time, and we kind of set out on a path at LAS to provide personalized wellness services to our employees, and we recognized at that point in time that the scale of post-pandemic issues associated with deferred care, a mental health crisis or a pending mental health crisis was not going to be sustainable, to manage those types of things internally without a skilled, well-equipped partner in our toolbox to help support the needs of our employees. Through that partnership, we offer wellness services to our employees, and these are very personalized programs. In the last week alone, I've received 3 sort of very compelling stories from our employees of how these services through WellSpark have really sort of transformed the lives of our employees, that have mitigated more complicated issues through kind of early detection of diabetes, mitigation of weight issues and obesity, to really sort of counteract some of those programs. But those are very, very personalized services with licensed coaches, wellness coaches that are providing those services to our employees, recognizing that our historic sort of one-size-fits-all offerings were not going to support the future in a post-pandemic world. I think Bert said it well. We too have incentivized our employees to perform wellness screenings, which obviously is sort of at the core of mitigating more complicated issues that can happen. And what we set out on the path this year was to really incent and offer lower premiums for employees to purchase health insurance if they completed some very basic, essential, what we consider to be essential wellness screenings on an annualized basis. And for doing that, we offer lower premiums to our employees for accomplishing those wellness screenings. And we're really beginning to see, even in the 12-month period of time, a significant decrease in on our spend on actual costs, and are really going to begin to see sort of a flattening of the curve, if you will, and have already relative to some of these more chronic issues and costs associated with treating chronic issues when we can catch them much earlier.
Absolutely. So one of the innovations during the pandemic was a pilot with Quest Diagnostics, Walmart, who we work with. We have a joint venture, and a company called Drone Up. So we started in a Walmart location just north of Las Vegas that can deliver a test kit to someone's home by drone. So think about how innovative that is, and that we can, deliver pharmaceuticals and other needed medical supplies to people who can't travel pretty quickly, and we'll avoid inner cities, but it's kind of a cool pilot. So Robert, pharmacies like Walmart and CVS and Walgreens and others have expanded their health services over the past several years. How do pharmacies and others play in this new world?
Yeah, I mean, I think that's the other thing that's really sort of emerged is the value that the pharmacies really have brought to helping us deal with the pandemic. Things like COVID testing, and then even more importantly, they've really served as a sort of key component of that distribution channel to get everybody vaccinated. And so I think, as I think about pharmacies, I think about really two things. I think one, the role of the pharmacists themselves, those professionals that sit behind the counter. And I think that they've emerged as sort of a much more trusted sort of healthcare advisor. And I think it's really as a result of, people having less access to their more traditional physicians. So, those conversations and those consultations, I think there have been many more of them. And I think over time now, as soon as that relationship is established, people feel more comfortable having those types of conversations on a going forward basis. If you look at some of the other trends that have emerged really across the country, not so much in Connecticut yet, is that there have been laws that have been enacted that really have broadened the abilities of what pharmacists can do. So for example, in many states, they can actually prescribe contraceptives. And we talked about smoking cessation just a few minutes ago. And again, and there are a number of states throughout the country where pharmacists could actually prescribe smoking cessation medication. And I think that's generally a good thing. And then probably a conversation ultimately we should at some point be having here in Connecticut. And then there's really the value of sort of that bricks and mortar, recognizing that, if you think about CVS and Walmart and Walgreens, I mean, they're basically almost in every corner, every neighborhood. And so they serve as a very, very convenient access point for people to go and get care. And the good news is that many of these organizations are being very innovative, and they realize that, and the types of services that they're offering now are really expanding. I think it was CVS that's now thinking about offering behavioral health services in its minute clinics, and so certainly that's a very good thing, because again, I think one of the things that the COVID pandemic has really pointed out to us is that we have an access issue. That access issue became much more acute during COVID, but guess what? It existed prior to COVID. So, even as we think about returning back to normal, I think one of the things we need to really be thinking about is how do we continue to increase access? And again, I think those buildings on every corner and every neighborhood, I think, are really going to be an important asset really going forward. I think a couple more things is, these companies typically have a very different view of customer service than traditional healthcare providers. And that's a very good thing, right? Because I think it's going to really kind of up the game and hopefully get everybody else to really focus more on customer service and the patient experience and how easy it is to book an appointment. And, you can get on your phone and you can see that there's 3 people or 4 people waiting in line in front of you at the minute clinic. So you don't have to be there right away. Those kind of things. So those are, I think, very, very positive developments.
The first time I went, there was a survey form afterwards that just said, like, how long did you wait? And the choices were like less than 5 minutes, 5 to 10 minutes, or more than 10 minutes. And I'm thinking, when I go to the doctor, it should be like 1 hour, 2 hours, 3 hours.
Yeah.
So their concept of service is very different, as well as their ability to serve people quickly. And they're open for many hours, including weekends.
Yes, and there's so 2 more things I'd like to point out. That's actually a very important consideration, because when we look at the access issues we have, it's really around after 5 and on weekends. So many of these locations actually offer those kinds of services, which is really important. And then the other thing is, as we're starting to look at some of our data that's really coming out as we sort of are sort of easing out of the pandemic, there's still things that are emerging that we're seeing that are relatively troubling, like, routine screenings. Even though they've come up, they're still below sort of pre-pandemic levels. So there's more work to be done there. We are seeing, though, however, emergency room visits are lower. And specifically, what we call avoidable emergency room visits are actually lower. And those are typically lower acuity type visits, which, in most cases can be dealt with in a lower cost setting, either in a physician's office or in an urgent care center, minute clinic. And so we're actually seeing utilization in our urgent care centers actually going up. And so what I'm hoping is long-term, this is actually a good thing because people are going to get care at a more appropriate place of care for what they really need that care for. So that hopefully is an encouraging sign.
So following Robert's comment on terms of access to care, one of the things that we really recognized during the pandemic was racial disparities. And the question is, how do we better recognize and respond to these health inequities going forward? And I'll start with Kate, and then I'll ask Eric to weigh in.
This is such an incredibly important and seminal question. First, I want to say we have to start by recognizing the longstanding nature of this. This has been illuminated by the pandemic. It is not created or exacerbated. It's a longstanding manifestation of structural racism that's reflected within our healthcare systems. So I think that piece, acknowledging the premise and the history of it, especially as that informs people's trust basis or lack thereof, and the ways in which we can engage and meaningfully address those, that's an essential starting point. I think another piece is understanding and capturing in data what is occurring. Many payers still don't routinely collect race and ethnicity data. We have historically always done so in Medicaid and Children's Health Insurance Program. It does have the challenge of being self-reported and not mandatory. So that data is not fully reflective and in many respects is pretty reductionistic in terms of people's preferred descriptors of their own history and ethnicity. So I think there's some constraints there, but starting from a data premise is essential. And I think we've been really informed as a self-insured Medicaid program by stratifying our data on that basis and really examining quite proximately. We have a very short claims run out compared to what we had historically in capitated managed care. We really can examine by categories of service, very specifically looking at gaps in care, access constraints, the incidence of chronic conditions, which is much higher, especially for African American individuals, and really call out the areas in need of intervention. I also want to say we must not wait for people to approach us. And I will say a specific example of something that our medical ASO did is it used claims data, but also American Community Survey data and other clinical data to stratify our entire population. They identified a subset of about 12,000 folks to whom they did affirmative intensive care management outreach during the pandemic. These are individuals who, because of their claims experience, social determinant needs, and other presenting factors, including their race, really don't have the same access or experience and are having a disproportionate risk of adverse outcomes. So I really think that piece is not common, really pushing out and saying to people, here we are looking to help integrate and knit services and supports for you. And I think the final thing is developing interventions that are directly premised in addressing these things. Two very specific examples in Medicaid. We are launching a supportive housing benefit under our Medicaid state plan that will help people in locating and maintaining stable housing. That's married up with housing vouchers from the Department of Housing. So it's a social determinant intervention. Also, we are developing a maternity bundle to address the absolutely unacceptable rate of adverse outcomes, especially for African American women in the birth process. And so I think all these features, acknowledgement of structural racism, tracking of data by race and ethnicity, the affirmative push to go out to those people and say, what do you need? How can we support you? And then very specific interventions that are targeted by category of service. All of these things have to wrap around to create a meaningful response.
Thank you. Eric, you, among others, have diverse workforce and have similar issues to face.
Yeah, listen, I think Kate said it very eloquently. I think from an employer perspective, in a practical from a practical point of view, as an employer, I would say in many cases educating our employee base on what their benefits are in a really simplistic way has become super critical for us to help counteract some of the racial and ethnic disparities we've seen in the healthcare system. I'd say consumerism, around healthcare is a very complex topic. And so breaking it down into sort of bite-sized pieces and having effective communication programs is key. And I also think ensuring that, an employer's internal educational resources on benefits are translated into multiple languages, to serve the constituents that you're offering benefits to, ensuring that you have, live or at least virtual sessions on a very regular, frequent basis, not just once a year when open enrollment happens, and employers tend to have a better communication strategy during a very sort of limited window of time. This is an evolving, strategy from an education standpoint for, increasing consumerism and making smart decisions and choices.
Thank you. Encourage participants to enter questions into the chat. We've got a couple of questions. First one's for Bert. So there was a post in the Harvard Business Review on when your employee discloses a mental health condition. Your comment about the tsunami of mental health is spot on. And from the post in the Harvard Business Review, employers are relatively new to dealing with such issues. And the question is, what type of legislative policies would help employers to address this situation, especially given half of the employees do not have ready access to care?
Thank you for the question. It's meaty on policy, certainly. I'll share this about current policy, perhaps, which is, we respect the discrimination rules around wellness programs. Have to. So we can't target populations with programming necessarily when people come forward. So if we have data and we know who's suffering from either a chronic disease or a health condition or a psychological condition, we can't target. So we're really focused on promoting the program so that people step forward. And when they do step forward, it's making sure that it's in complete privacy, with HIPAA protection and all of that. And when we report to employers, it's all on an aggregated basis, making sure we are protecting the privacy. Going forward, policy, I would say that there's mental health parity with physical diagnosis, and I don't know, I'm going to throw this one back to my colleagues to talk about policy. I can tell you how we operate in today's policy, which is to make sure that employees are protected from being disclosed as it relates to their employer, and then making sure that programming is really, really available and relevant to that and accessible, going back to Rob's comments on telemedicine, and making sure perhaps policy is around coverage and making sure that coverage is more widespread than just being, for an employer rather than just benefit eligible, and having these benefits as part of a benefit suite. Perhaps making them more accessible through mandatory coverage, so that an employee isn't left on the outside looking in if they don't have benefits. That's just something off the top of my head to offer. I throw it back to my colleagues for any other suggestions here. Hearing none.
Anyone want to weigh in?
Yeah, I'm happy to just offer that I think that last point around kind of enabling tools for telehealth is very important. Our legislature has just passed a very comprehensive bill that defines, eligible practitioners, the pieces Robert was speaking around, the mechanics around the originating site, et cetera. There's a lot of detail in there. And then also, pieces around payment parity. So I think those things all undergird, the future coverage. The first point you're making around the data privacy issues, I just want to revisit, because I do feel like there is certainly obviously a shared interest in protecting the sanctity of an individual's data privacy, but I do feel like we're not shaking out enough on the side of facilitating use of the behavioral health data for integration. In our major primary care shared savings initiative, we don't have the ability to push the behavioral health data, the practices as we do the medical claims data, and it does inhibit some of the proximate integration of the BH services that I think would otherwise be feasible. And I just think that's a tension. It's a constructive tension that has to be, continually addressed on the federal level in terms of how we build that into modern practice, which isn't, isolated or compartmentalized into these kind of various facets of care.
Yeah, so one of the observations earlier on during the pandemic was that anti-anxiety drugs, antidepressant drugs were up in terms of utilization. There's clearly social isolation, people dealing with other members of their house of all ages, struggling to deal with elder care, child care. There's a lot of additional stress that people were not accustomed to and made it more challenging to deal with. That's one of the residuals of the pandemic. Last sort of question for everyone is, let's pretend we fast forward to 10 o'clock on June 2nd. What's your organization going to do to roll up its sleeves to get work done to address healthcare in this brave new world? I'll start with you, Kate.
So thanks for the question. So we are definitely a program that's constantly reform-minded. We have invested a lot in primary medical, behavioral health, and dental services. I think that does distinguish Medicaid coverage in Connecticut. It is a very broad array of those prevention services, and that's really the root of our approach from a care delivery standpoint, to be approximately providing access to and promoting utilization of those services as they contribute to an individual's kind of stewardship of their own health goals. We need to grade those services. I talked about the kind of proximate behavioral health integration piece that we're looking for through our primary care practices. We also need to layer in the feedback loop and the connections with the community-based organizations that support individuals with social determinant needs. And in our PCMH Plus initiative, that all those factors are really intentionally linked in terms of what we can do to promote outcomes. I'd say going forward, building in the permanency of a broad array of the telehealth, like I said, not just for medical and behavioral health services, but looking across the age continuum. We use this for support for families with autism. Some of our folks who receive long-term services and supports and may have mobility constraints, people with disabilities. All those folks, I think, have really different, if you will, use cases for telehealth, but they encourage a kind of diverse application of that benefit. And finally, I'll say our major focus ongoing is that disparity work. The maternity bundle that we're developing is just one example of bringing to bear the value-based payment levers in an area that must be catalyzed towards improvement of outcomes. And that is outcomes related to our traditional, descriptors of the quality indicators, but also the lived experience of the members. And that's particularly important qualitatively when you're addressing historical disparities. Finally, we are looking at matching data and across domains so that we address some more of those social determinant pieces. So thanks so much for the question.
Yeah, thank you, Kate. Robert, in 1 minute or less.
So really quick, I think our focus really here is around leveling the playing field in terms of access to care and healthcare outcomes. ConnectiCare has a very diverse population of members. We're in the individual market. We sell small group, large group business. We sell Medicare business. So we really want to make sure that all of our members sort of have equal access. And when I think about, two of the most important things that we did as a result of the pandemic, one which I talked about already, which is the changes we made to telehealth, but we actually had what we called a peace of mind program, which is we identified our most vulnerable, our sickest members, and we called them and we asked them, how can we help? Right? And that really helped us to identify the struggles, the questions, the social determinant barriers that people were sort of dealing with. We started to document those into our care management systems so that we were better informed about the needs of our members. So we were able to connect them with various social agencies for childcare, for rental assistance, transportation, things like that. So our commitment is that we're going to continue to do that. And I think lastly, certainly one of the things we've realized is we need to do a better job in collecting race and ethnicity data so that we can really better understand this and also better understand the composition of our network and make sure that we have a network that's as ethnically and racially diverse as the members that are utilizing it.
Great. I love the outreach. Eric, very quickly.
Yeah, I'll go very quickly. I would say, the things we're sort of doing from an employer perspective, providing quicker access to care is one piece. I talked about education. That's going to continue to be a critical part of what we do. Broadening and increasing, eligibility to, a much larger population in a quicker way, obviously to help mitigate, issues and, provide for early identification. And I think broadening our own, personalized wellness programs in partnership with WellSpark to really help sort of drive, better adoption of wellness as a core strategy.
And I just want to thank you, Eric. I just want to call out Robert, really applaud what you've done with the Husky Health members and the 24/7 nurse support. It does make a huge difference. Roberta, finish up.
Yeah, I'll finish where your last comment before you opened it up, Harvey, which is you were talking about all the stress of everyday life and how everyone's world in going into the pandemic and coming out of it, quite honestly, it's like the worlds were shaken like a snow globe. That's my analogy. And it causes stress. And if you're a caregiver to aging parents, or children are now in the home, and it's very stressful. So I think what I would offer is this: we at WellSpark, because of our biopsychosocial approach, it's the social work leg of that stool that's really, really come into focus, and how we are really trying to enable employers as change agents. So to look at their programs in new ways and to make sure the programs they have are accessible to the entire workforce. So I'll leave you with that.
Great. Thank you, everyone. And now to close us out for this morning, turn it back to David.
Good afternoon or good morning. I'm having a little trouble.
Still morning.
I apologize for the disembodied voice. But thank you to Dr. Kaufman, and there we go. Sorry, everybody. Thank you, everybody, for your participation in today's discussion. Thank you, Dr. Kaufman, for your moderating our panel. Thank you, panelists, for your time this morning. I think this is a situation that is unique in our time, and I appreciate all of your input into helping us understand what it is that we have to look forward to. Speaking of looking forward to, our next Connecticut Health Council event is on obesity, the health and financial impact. So I invite all of our participants today to join us on September 9th at 9 a.m. for that event. As always, I appreciate your investment, not only in the Metro Hartford Alliance, but in our region, in making our Hartford region the best place to live, work, and raise a family. So Thank you again for your participation today, and I hope we see you all soon. Thank you.
Thanks, everyone.